All right, folks. So this is our first um, kind of more formal. So we're introducing our masterclass in Gait. As I say, the Gait guy's way, it doesn't really matter. We're introducing, this is a very cursory interview. We're going to be putting this video out to everybody. Obviously, if you've gotten this, you're obviously following us in one way, shape, or form, or someone shared it with you. This is similar to what we've been doing with our Patreon folks at the $10 and $20 and $50 levels. They get different levels of complexity of this stuff. But we've decided, as you heard in our last podcast, last two podcasts, that we've decided to do a masterclass. We've been teaching online for quite some time. We've been teaching in schools and universities for a while. And I've been doing a lot of teaching in lecture halls and whatnot. And I've kind of backed away from that a little bit because I don't enjoy the lecture hall anymore. But I do believe that there is some value in internet teaching and web-based teaching. We decided at least to try it this way for a little bit. And at some point, I know that I'm going to have to appease Ivo and go into a lecture hall with him at some point and do a master class. And we're going to do that. But and that'll be more of a hands-on component, I think. But right now, let's get you guys the meat, the material that you need in order to really feel good about this material. And depending on what level that you're a patron subscriber, you may be getting this for free, or you may be getting it at a deep discount. And for those people who don't follow us on Patreon, you're going to be paying a small premium. But we would recommend you going over to Patreon, patreon.com, over and type in the Gait Guys and see what levels you'd like to contribute at and see what kind of discount you can get on this course. So we don't know how many sections this could be. It could be 5, it could be 8, it could be ongoing for 2 years, and it could be 20. We will have this on a paid Vimeo page or something like that. We haven't decided yet, but we wanted to give you guys one of our favorite slides. And this is a slide that Ivo is just an absolute wizard at. I'll chime in a little bit here or there. And this is just kind of a brief overview in one plane. Actually, that's not true. We're going to show another slide of showing a bird's eye view, an axial view. So we're going to be looking at sagittal progression of someone walking and just the breakdown from our good friend Thomas Michaud's book. Is it Michaud or Perry's?
Actually, this is from the Ranchos Los Amigos Gait Lab.
Okay. Yeah. Okay. So, and we want to give them credit. It's a great slide. And I'll let Ivo just pull up that slide now. We will go right ahead into this, and I'll let him take over. And we're just going to kind of riff off and back and forth. This is this can be very loose and informal. At times during the masterclass, we will be doing this type of thing. We will be putting up video cases. We will be putting up corrective exercise slides. We will find something wrong on a case. We'll stop the slide. We'll say, look, this could be A, B, or C, and here are the corrective exercises we might entertain. These are the exam things you may want to look into if you're concerned. So, obviously we can't do the hands-on stuff, but we can show some videos of some hands-on stuff and corrective exercises. It's going to be a deep knowledge course, conceptual course, but we got to give you the material. And today's just kind of a shadow, a brief glimpse, a sliver, a crumb of what we're going to be offering here. But we wanted to make sure you guys knew the quality of the material and the depth that we're at times going to go into, because this stuff gets very complicated. And on that note, people always say if you can't make something complicated simple, then you don't know what you're talking about. I don't disagree. But some things are complicated and you can't simplify them, because then you lose some of the depth of knowledge, the information that makes it possible to digest it, to understand it, so that maybe someday you can make it more simple. We call this a Gait Masterclass. You're going to struggle with some of this material, as we did as well, and as we do still today at times in our clinics. We will show you cases we're working on. We'll show you cases where we had an epiphany. So that being said, hopefully you get that. This is just a sliver of what we're going to offer, but we wanted to throw out something just to kind of get our whistles wet here and kind of get rolling. So next week, next month, we're not sure when it will be, but it will be very soon. We can go right into part 1 and just dive down into this masterclass. So that being said, Ivo, if you want to take the mic and do anything or say anything else, I can just say anything else. Don't do anything else. Just say something.
Yes.
Otherwise, let's go into this Gait slide here. So
it was funny when Shawn and I were putting this class together. We were talking about like what we should do, and it's like, oh, we should just have a screenshot of the two of us up front. And I'm like, dude, neither one of us are poster children for anything. Aging chiropractors going on.
Kneecap.
But anyway, what we want to do is bring you some of the information we talked about. Some of this will be review, of course, for some of you, and some of it may be new kind of material. As far as the format goes, I don't know, Shawn and I haven't really talked about this, but in my mind, the way it was is we've done some gait classes before. So we're basically going to be taking slides from those gait classes and kind of going through soup to nuts, start to finish. It actually, believe it or not, started at a presentation, and your memory probably serves me better than mine does, Shawn. But when we did that thing at NUHS in Chicago,
Yes.
So it was a presentation. Shawn said, "Hey, come on out. We're going to talk at the college." So I was like, "Great. What are we talking about?" He's like, "I don't know. Just come out and we'll just talk." So I remember sitting at the airport eating ice cream, and I was watching people walk, and I was noticing people in flip-flops, don't have any ankle rocker. So I took my camera out and I started filming, and that became the entire talk. We talked a lot about that as well as other gait-related terms. So we're going to take that and sort of put that on steroids along with video. So that's how I envision the class would go. Kind of like if you are Patreon, you know that we've had some other presentations that we've done, and we've taken presentations that we've classically done on online CE that were, maybe 50 minutes, 60 minutes, and made them into several hours as far as that goes, just because we can dive in deep and we don't have any time constraints here. So we can.
And I think that's really important that you guys hear, because some of you will think, oh, well, you've taken your classes on online CE or Chiro Credit, and they're 50 minutes. If you've been on those shows with us, you know how rushed we are, because we are on a tight clock because of the way the system is set up. And like I said, we took a 50-minute presentation and drew it out to 3 hours. It might be even 3 hours and 10 minutes or 15 minutes, because we can go into the nuances that we cannot go into on that platform. But we can do it here, and we can insert videos, we can talk, we can do all kinds of things. And that's what we want to give you guys in the masterclass, because that detailed stuff is the stuff that really gets through and really gets your principles of how this stuff works, into your brain, and so you can use it. So
it all kind of starts with the Gait Cycle. So this is a picture. This is from the Ranchos Los Amigos Gait Lab, Jacqueline Perry's lab. This is out of their book. It's a slide that we use to teach all the time. And I like it because it's got the newer gait terms, which are the more modern stuff on the left-hand side here on the top, and then the classic gait terms. So the classic stuff is this original root, orient, and weed stuff as far as going through the gait cycle. Some people still use that. The newer gait terms are nice because they describe the different sections in the gait cycle. And we talk about both stance and swing, but it breaks it down so it's much more biomechanically digestible. So we'll go through that. The big thing we need to understand, this is a picture of ideal gait. This isn't what we're going to call normal gait. This is what we would like to see. This is what we could expect if everything was working appropriately. And as we know, that's usually not the case. But as Dr. Carrick always used to say, if you look at enough normal, then abnormal will jump up and bite you in the nose. So we need to understand what's supposed to happen before we can think about, oh, well, what is actually happening here? So we're going to grossly divide gait into a stance and swing phase. Stance is about 60% of the walking gait cycle. Swing is about 40. It's actually 61 and 39, but 60-40 divides up a whole lot nicer. And then stance phase is divided into kind of a contact phase and a non-contact phase. So we start at initial contact. That's when the heel first hits the ground. When the heel first hits the ground, we need a sufficient coefficient of friction between the ground and the heel or the shoe or whatever we're having to take the calcaneus and basically halt it. When the calcaneus halts, then the talus is going to slide anteriorly on the calcaneus. And it'll do so on either 1, 2, or 3 facets, depending upon that individual's morphology. Not really that important whether it's 1, 2, or 3 as far as the mechanics that ensue, but just understanding that that's what can occur. The talus will then plantar flexed, adduct, adduct, and evert. And that's basically what's going to initiate pronation. So if we don't have sufficient stoppage of the calcaneus, that never occurs. Okay, if we don't have sufficient motion at the subtalar articulation, in other words, the talocalcaneal articulation, that's not going to occur. So it's super important that each of these things happen. So we have the heel, greater coefficient of friction, talus slides anteriorly, plantar flex adducts, everts, and as that's occurring, pronation starts to happen. While that's occurring, we're going to start to get medial spin of the lower extremity. Okay, and that medial spin will be attenuated by musculature up the lower kinetic chain as we go along. So let's just get through the cycle here. So we have initial contact, then we have loading response. Loading response is what happens when that foot starts to get loaded. So what's happening, the talus is sliding anteriorly, the tibia is rotating medially. And throughout loading response, we're getting this slow lowering of the foot down. And that's because of the hopefully coordinated eccentric activity of the anterior compartment musculature. And Dr. Allen is always talking about we need to gain anterior strength to gain posterior length. And that's true because we're going to need something to attenuate this foot from falling down. So you got the tibialis anterior, the extensor digitorum longus, the extensor hallucis longus that are primarily the ones that are going to act. At that point, you could say peroneus as well, but the peroneus really doesn't start to contract until we get later in the gait cycle. So that should not be involved initially. So we get this slow lowering of the foot until it gets to the ground. And we used to call this foot flat because that's where the foot was flat on the ground. But this is all part of loading response. All the while, I am having continued plantar flexion, adduction, and eversion of the talus. I'm having medial rotation of the tibia, and that rotation needs to be requisite for appropriate gait to occur, 4 to 6 degrees of internal rotation of that tibia, and that needs to be attenuated. And we'll get back to that in just a moment. So I've loaded it. Once I start to get the loading response, the foot is down, the body starts to move forward, and I get to the point where the body is exactly over the middle of that foot. That's mid-stance. That's when the maximal amount of calcaneal eversion from that calcaneus hitting the ground has happened, the maximal amount of internal rotation of the tibia, the maximal internal rotation of the femur has occurred. This is an important, you can kind of think of this as the middle portion of stance phase, which it should be appropriate. You know, sometimes this portion of gait will be abbreviated, sometimes this portion will be abbreviated, but this should be about the middle. Okay, so it's about the about 28% of the entire gait cycle, but about half of stance phase that should be occurring at that point. So this action also requires for appropriate motion to occur for the opposite foot to come into swing phase. So you'll notice here that the left foot is leaving the ground. As the left foot leaves the ground, that starts to cause a small degree of external rotation of the pelvis to be initiated in here. And hopefully the flexion of this opposite extremity is going to be initiated by the abdominal musculature, particularly the external and internal oblique muscles, but also transversus abdominis and of course rectus femoris a lot. And then it will be perpetuated by the iliopsoas grouping as well as the rectus femoris, the tensor fasciae lata, portions of the gracilis as well, which can all act to assist in thigh flexion as well. As that's going to occur and this foot comes off the ground, that will help to initiate external rotation of the pelvis once it passes midline, and that should be occurring at mid-stance. As that continues to go further, that's initiating supination. So now we should start to see external rotation of the tibia, external rotation of the femur, and that talus, which was plantar flexed, adducted, and everted, should start to invert, dorsiflex, and abduct. Okay, and a lot of times you'll notice when you're watching people, you'll notice that their foot flares out during the second part of the standing gait cycle. In other words, after mid-stance, and that's normal because the talus is abducting. We should be seeing that splaying occurring and relative abduction of the forefoot. Then from mid-stance, I get to terminal stance. So terminal stance is the point at which the heel is last on the ground. Okay, so I had supination occurring, the peronei kick in, hopefully at about mid-stance. The forces are traveling up the lateral surface of the foot, coming across and starting to exit out through the great toe. So at this point, it's the maximal amount of dorsiflexion occurring at the ankle. So speaking of that, we need a certain amount of ankle dorsiflexion for everything to occur normally. If we have about 10 degrees of ankle dorsiflexion, that means that this thing can generally proceed. And the ankle dorsiflexion needs to be able to meet the amount of hip extension present as well. So when we're at terminal stance, right before pre-swing, when we start to get heel rise, the amount of ankle dorsiflexion should equal the amount of hip extension. We call that the Z angle. And we've lectured on that and talked about that. In fact, I think we did an entire presentation just talking about that particular action. So I've got this slow eccentric lowering of the foot with the anterior compartment. I've got control of pronation basically occurring up to mid stance. And what's controlling that? Well, some of our deeper posterior compartment musculature, largely the tibialis posterior is going to be one of the primary ones, the flexor hallucis longus, and the flexor digitorum longus. That's what's going to help to maintain and decelerate some of the pronation occurring in the foot down at this level. Okay, so I'm at mid stance. I've started to initiate supination. The contralateral leg is going into swing. I get to terminal stance. That's the last point. Maximal amount of ankle dorsiflexion, maximum amount of hip extension at that level. 10 degrees is what we hope for. People can get by with 5. When they have less than that, that's when we start to see pathology. And then I get into pre-swing. Pre-swing is right when I have dorsiflexion of the great toe. And that dorsiflexion is important because when I dorsiflex the first metatarsal phalangeal articulation, that helps to initiate flexion of the knee along with contraction of the posterior compartment musculature, particularly gastroc, which crosses that joint. And as I initiate that knee flexion, that's going to enable me to be able to pick this foot up and bring it forward. So I've got pre-swing, which is the point of hallux dorsiflexion at this point, and I'm starting to get abdominal contraction for initiation of this foot coming into swing phase. Then I enter swing phase about 40% of the gait cycle, and I have initial swing, which is largely an acceleratory phase. So I'm using my core musculature to accelerate this. Mid-swing, which is electrically silent, in other words, coming across, so now this leg is in swing, this side is starting to supinate. And then I have terminal swing, which is largely an eccentric contraction occurring. And that eccentric contraction is seeking to help to decelerate the foot to get me ready for the next heel strike or initial contact on this side. So coming back to the initial part of the gait cycle, when I have initial contact, loading, response, I've got this internal spin of the lower extremity. And we talked about that being attenuated somewhat from the tibialis posterior as well as the posterior musculature. And if you think about all these enclosed chains, they're external rotators. So they're eccentrically contracting as the leg is internally rotating, but we also need stability coming from up above. So the musculature that's going to assist in that, believe it or not, is the quadriceps, which are dampening. And we think of like the vastus medialis as being an external rotator, the lateralis as being an internal rotator, and you can wrap your head around that one in one of our other lectures talking about that. But in addition to that, we have co-contraction of the hamstring. These guys contract almost electrically at the same time during the gait cycle. And we have contraction of the deep 6 external rotators, starting with the superior and inferior gemelli, obturator internus, externus, piriformis, and the quadratus femoris. And they're going to decelerate this internal rotation of the hip as well, all the way until we get to mid-stance. So they're contracting eccentrically up to this point. And when I get to mid-stance, then they start to contract concentrically as I go through the remainder of my gait cycle. Suffice it to say, it's complex. There's a lot of stuff going on. You can think of simple things like when the heel hits the ground, the coefficient of friction is greater here. And as this foot goes to loading response and the foot becomes flat, now I've got a shear force at this femoral tibial articulation. Well, when the heel hits the ground, the popliteus contracts. And what the popliteus does when it contracts there is it protects the PCL. So remember, when the foot's planted, it's the posterior cruciate ligament that helps to prevent anterior translation of that thigh. The anterior actually helps to translate posterior displacement of the thigh. So the popliteus contracts, and the popliteus is cool because it goes from the medial part of the tibia to the lateral part of the femur. And what that does is it's going to eccentrically contract, again, to help control internal spin of both the tibia and the femur as I get to mid stance. And that's important because the tibia, during the first pass of this gait cycle, has to rotate much, much faster than the femur does. And if it doesn't, then I'm going to bind the meniscus in that area. I'm going to have a problem. The popliteus is one of the muscles which helps to ensure that internal rotation occurring at the appropriate rate. If that's not contracting appropriately, then we're going to have a problem. So when I go from mid-stance to pre-swing now, the popliteus is contracting really, really hard and concentrically at this point, which is going to spin the femur, hopefully at a faster rate of external rotation than the tibia, again, so I don't bind the meniscus at that level. Now, how many times do you see people with some kind of pathology, which Shawn will start talking about in just a second here, like forefoot varus or an inverted forefoot or supinatus or something like that, where this acceleration is accelerated, they're too far into pronation at this point, and now you've got medial knee fall, and I can't externally rotate that femur fast enough. And I start to get binding and medial knee pain, and now the quadriceps are all wonky because they're not contracting at the appropriate angle here, and now the pulls on the lower leg aren't the same, and that's going to create a whole nother ball of wax for things that are happening. And if that wasn't complex enough, thinking about the popliteus contracting now eccentrically to mid stance and then concentrically to toe off, and then pretty much at toe off, it turns off. The popliteus doesn't do anything again until the next heel strike. The other thing that we need to think about are the adductor muscles. Now, the adductors and the gluteus medius are the only muscles which pretty much fire continuously throughout the entire gait cycle. They're the only two muscles. Now, if you think about the attachments of these guys, the gluteus medius is unique in that it's shaped like an inverted triangle, and the anterior fibers are internal rotators, the middle fibers are abductors, and the posterior fibers are external rotators. And if we think about the attachments of the adductor grouping, okay, they basically attach pretty much posteriorly, so they concentrically externally rotate the lower thigh. And we talked about this in our last podcast. We were talking about groin injuries in Australian football players, how it's an eccentric controller of internal rotation, then concentric during external rotation. And you could think about the gluteus medius as acting kind of opposite that. So that's also helping to control some of this medial spin, which is occurring on. The problem is we've got all these things occurring during the first half of the gait cycle, and they occur during the second half. But if the mechanics are off and the mechanical pull, the angle is different because I've got an tibial varum, or the knee is too far internally rotated, or I've got an increased valgus angle with the knee, or anything like that, then all these things go wonky and the muscles don't contract at the appropriate time. And then that causes temporal dispersion, and then that's what causes other problems with the gait cycle. So big things we need to remember: internal spin to mid stance, external spin there that needs to be attenuated. When I get to swing phase, I need to initiate thigh flexion, start with the abs perpetuated by everything else. Okay, I'm going to accelerate. Mid swing's largely electrically silent. And then at terminal swing, I need to decelerate this leg as it's coming down. And that's going to occur partly from the glute max, but the glute max really only fires at heel contact and toe off. Those are the only two times it fires. It's largely a glute med phenomena, which is decelerating that, along with the hamstrings. And if that mechanism is not working appropriately, then I've got the lumbar erectors at this particular area, which are going to have to take over. And that's where you're watching that person walk, and every heel strike, you watch the lumbar erectors contract on that side, and it's going boom, 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 every single heel strike. You know right away that they're not attenuating appropriately, and then you can kind of go from there. All right, I've been rambling on here, Shawn, for quite a while, so I'm going to let you go.
No, that's awesome. And this is the stuff that people so what you guys just heard there was Ivo for 20 minutes just being able to riff on the normal gait cycle as someone moves through the sagittal plane. Obviously, us as observers are looking at this sagittal plane slide, and we are looking at it from the frontal plane. So we're going to see only sagittal problems, unless you've got a really good trained eye, and we're hoping that at the end of the masterclass you will have a better trained eye for that. But you're going to see sagittal plane problems like step length problems, like premature heel rise. You're not going to see other things, though, that are maybe more axially related, like a narrow step width or a widened step width. You're not going to see the effects of internal tibial torsion or external tibial torsion or femoral torsion, for that matter, or talar torsion. You're not going to see, unless it's really, really obvious, the effects of supination or pronation in their excesses in the sagittal plane. So you need to be able to understand your client's gait in the sagittal plane, which is what this slide is. Then you need to be able to understand your client standing in front, so you can see how they're moving in the frontal plane deviations as they move towards you sagittally. Like if you're standing at the front of a treadmill and they're walking on the treadmill, you're seeing them progress through the sagittal plane, and you will then see the frontal plane deviations. Whereas on this slide, and I think I may have said it wrong, you're seeing them moving forward in a sagittal plane progression, but you're viewing them from the frontal plane, so you'll see the sagittal plane deviations. If we were standing on the ceiling looking down, you would see someone moving through the axial planes, and you might be able to easily see both sagittal and frontal. That's obviously a difficult one, or if they're walking across glass. So this is where you need to have a good grasp of what norm is. And if you know what the normative gait things are, and you can see what, and you understand what happens in the norm, then you can start to more easily see the things that we like to put up on Patreon and some of our posts, which are the deviations of those planes, which are problems that then cause a compensation. The compensation usually is what you see. You don't see the problem. Usually you see how they move around their problem. And then we'll give you some of our insights on what you might find on a clinical examination that might be driving those things that you see, which are a deviation or a failure or a compensation in one of those planes. So on this slide here, and let's just talk about a couple of things. This is the normal gait cycle. It doesn't take into account torsions or forefoot types. What if it's more on one side than the other? Now you've got two legs that are different, and it sets you up for a different stance phase effect on one side as compared to the other. So you may see adaptations in your client through the pelvis to make up for that. It's not going to make up for differences like a loss of ankle rocker or a loss of knee extension or flexion on one side. And if it's unilateral, then there's going to be an adaptation on the other side, maybe a longer step length or a deviation into the frontal plane. This is where gait analysis gets very, very challenging. And these are the things you might get on a high-end stop frame or sensor-based gait analysis, and you're going to see these things. But if there's no clinical exam and there's no understanding of the reasoning behind what you're seeing, then any recommendations that are made off of those types of gait analyses are going to be basically making recommendations to change what they're seeing or what the sensors are saying, not the reason why that sensor is saying what it's saying. That's the key to getting good at this game. I had a gentleman in who flew in from the West Coast a couple times over the last year, and as we worked through his problems, it became quite evident as things started to improve, as he worked on his homework and peeled back layers. It was quite evident that the primary problem was that he was taking step lengths in the sagittal plane that were too long for the amount of ankle rocker that he had. So in other words, there was constant premature heel rise. I just had a gal up from Florida that was frustrated that she couldn't get any help elsewhere, and it was largely the same thing again. A lot of people have these long steps, but they don't have the core control to manipulate their body's mass over top of that long step. And they might not have the ability to move across an ankle that with that long of a step. They might not have enough ankle rocker, and so they go into a more premature forefoot load and develop, and both of them had forefoot type symptoms. You may end up going into knee hyperextension on one or both sides if the step length is too long, longer than what you can control, longer than what you are durable for, and that you can fend off symptoms with. So, and remember, those things are then going to have to, if you don't have sufficient ability to do that, you may end up compensating at the core level with a deviation in the pelvis in the sagittal plane, anterior or posterior. You may go into a sway back posture. You may find that that's not sufficient enough, and you may move into the frontal plane in order to make up for the deficit, because that's another place you can go. So things do get difficult when these normative phases are not met with clean mechanics. Ivo talked about, the early phases of gait there, from heel strike to foot flat to mid stance. And he talked about being able to control rotation of that limb, controlling the rate of internal rotation from heel strike into mid stance. Well, what if your glute is weak and you can't control it? And maybe it's only weak in the eccentric phase. Maybe it's fine in the other two phases. And you can't control the rate of internal rotation of that limb. So it happens too fast. And now it's happening too often, and it's happening too much. Well, spin can also be accommodated for at the foot level. So maybe you overpronate on that side. Maybe you step across the midline, or maybe you don't. Maybe your step width is wider because you know that a wider step length will reduce the amount of internal rotation. So there are those variables as well. But maybe it doesn't show up until you fatigue. So maybe you're a runner and that glute doesn't fatigue until the 7th mile, and then the symptoms come out. These are the types of things that I talk about on our online CE classes, and you've heard it on some of our podcasts and many of the Patreon type extras that you can easily get from us here. So these are the types of things, and that's just some cursory examples of some of the things that we look at. You know, maybe the hamstring is short, maybe the quadriceps is short, maybe they can't go into enough knee flexion as they're going through mid-stance. And so those are just some examples of the things that we like to look for, the things we like to talk about, the things that we like to work through mechanically of, well, when this is wrong, then you have to do this. Now, can you see that on this client's gait cycle? And we'll stop, frame it. Hopefully we'll have some cases that show that. And now the lesson becomes something visible. Now the learning becomes a little deeper. So again, you need to be able to have the grasp that I've just displayed of just what normal is if you are going to have any chance of determining what abnormal is. And so we talked about torsions. I was just writing a couple things down while he was talking. And so you also need to understand that on the stance phase leg, you're in a closed kinetic chain. But in the swing phase leg, you're in the open kinetic chain. So I said something that we love to talk about, that the tibial, that the vastus lateralis in the closed kinetic chain, when the foot's on the ground, it has an internal rotation job. But in the stance phase, it's going to have an external rotation job because the fixation is at the pelvis now, not at the foot into the ground. So you need to be able to look at these muscles and understand what they do to the different joints that they cross and the other different joints that they can affect either directly or indirectly, depending on if the foot's on the ground or if the foot's in the air. Then you need to understand oh, wait a minute, this process is being juggled at the same time. One leg is in open kinetic chain while the other one is in closed kinetic chain. So this is where we come into what we call juggling. You need to be able to look at someone and understand where the juggling is being failed so that you can start to limit it down to, oh, this looks like a stance phase problem on that right side. Or maybe it's the right side symptom, but it's a swing phase problem because the targeting ability of the hip abductors is off. But maybe that's because they're moving through the sagittal or the frontal plane on the stance phase, and it's affecting the targeting of the glute, the hip abductors like the glute medius and whatnot on the swing phase side. So I know some of you your heads are starting to spin a little bit because this is a lot of fast talking and juggling, but we hope by the end of the masterclass, this is the kind of stuff that you could follow us in a dialogue and really have a good conversation, or follow what we're talking about at this rate in looking at someone's gait, and we could just have a conversation without breaking it down into minutiae of detail. Now, that being said, you have to start slow. You have to break things down at the beginning, and that requires some studying. And that's where we've always loved Thomas Michaud's book. We love Perry's book. We love the Ranchos Los Amigos work, which is where this came from. So you need to come to this with some basics, but it doesn't mean that you can't keep coming back here multiple times if you're a paid client and look at this stuff and just kind of take it and go over it again, because this stuff is repetition. So I guess that's all I wanted to say. And then maybe one more thing before we look at that other slide. Weaknesses and pathology, whether it's a ACL repair or it's a hallux rigidus or it's a impingement at the hip, or it's a posterior ischiofemoral impingement syndrome, or whatever. These things create compensations which drive asymmetries, and the asymmetry then may drive some symptoms. In a post I put up today for our Patreon folks of me on the treadmill going through how to actually get into the combination of the glute medius in a lunge and in walking, with the glute is in contact or is active in the stance phase, and the abdominals are active in the swing phase. I discussed some of these asymmetries and how you need to be able to turn these things. I just lost my train of thought. That happens when we go deep dive in here. Asymmetries, and the asymmetries will throw you off. And some people have learned that through some what I would consider maybe slightly less educated dialogues on social media at times, which could include ours, arguably.
Don't get me started.
Which could include mine, discussions by some people's knowledge base at times. It may be very rudimentary compared to some wizards out there. That you don't have to change anybody's gait. That's just their natural gait. And, you know, as long as they're asymptomatic, then just leave it alone. And I made I think, a really good argument for that today on our Patreon post, as I have in many of our posts. I know you have as well, Ivo, that just because it doesn't come with symptoms doesn't mean that if it's pathologic enough, it might not drive some symptoms down the road. Yeah, you could take the other side of that argument and say it's not a problem. Leave it alone. Once it's a problem, then it's a problem, then you can address it. But we've been doing this long enough. You and I have well over 50 years combined at this game, and we know that you just can't leave that alone. I mean, you're just not going to want to leave a diving valgus thrust knee alone long enough for 20 years and not expect that there's going to be a repercussion on the collateral restraints and the musculature, both at the knee level and at the hip level and at the foot level. Something's got to give. The loads are going to go somewhere, and loads over time create tissue change, tissue adaptation, but also tissue failure. So there are some times that it's very appropriate. Oftentimes, I will argue that you have to know what's normal and you have to know what's appropriate. And if a client can't control something, and if it's not symptomatic at that point, it doesn't mean you shouldn't be making some adaptive changes to clean up their gait a little bit more, to preserve their system a little bit more. Because we know we are all on a time clock here, and preservation of tissue is one of those things if you want to stay asymptomatic. I'm going a little rabbit hole-ish here, so I'm going to stop.
It's okay. So just a couple quick things. Looking back at this, so Shawn, you brought out a really good point that we're looking at sagittal progression from a coronal plane as frontal plane. Well, coronal and frontal.
Oh, excuse me. Yes, excuse me.
Yeah. From this. So things you're going to see from the side are things like premature heel rise, step length, hip extension, arm swing, vertical oscillation. Okay, those are the things we're looking at as far as that you're going to see from the side. From the front, you're going to see coronal plane movement viewing them from the sagittal plane. So you're going to see side-to-side motions. You're going to see vertical oscillation as well. So those are the things you're kind of thinking of. And ideally, you want to film people from the front or the back or both, the side. And then ideally, if you can get kind of a top view from there, you could just hold your phone or whatever you're using to film with over that. Now, you can get expensive video equipment. If you own an iPhone, the slow motion feature is just key. It breaks the frame rate down pretty well. You don't get a lot of degradation, and you can see a lot of stuff very, very easily. And most people already have this technology at their fingertips, just a matter of using it. Do the same thing with an iPad. As you're doing that. So you don't need lots of fancy equipment. Yeah, the fancy equipment is really nice and it's fun to play with and this other stuff. And it's good to know that there's a millisecond difference from side to side. But the bottom line is, what's happening in the gait cycle and how is that potentially relating to what's going on with that individual and the reason that they're in your office, symptomatically or asymptomatically. I love it when people come in for performance enhancement stuff and like to think that we're able to help them with that, but usually they present with a problem. And we were recently criticized on social media for not being evidence-based. And it was on a neurological case that I was talking about of a gal that had a cervical myelopathy and she had abnormal gait. And I was going through what was going on. Now, I honestly don't see how that's not outcomes-based, but Shawn and I had a big discussion about it. And as a result of that discussion, unless it's an intelligent question, we're not going to respond on social media and do something like that. But the point is we're outcomes-based. So it's, are we making a change? Is there a visual change? Is there a symptomatic change in what's going on with the patient? Now, there may not be a lot of evidence to say that people with cervical myelopathy spend a longer time in stance phase and have more medial knee dive. But when you're looking at somebody with that history and those things are evident, I think that probably shows that, yeah, there's definitely a correlation there. It may not be causative, but there's definitely a correlation that's occurring with that. So with that being said, let me
just throw in something on that, because I gave that some more thought. And one of my primary beefs with the evidence-based stuff is show me an article that goes over the type of stuff that you and I are going over. Someone has a frontal plane pelvis drift. they have internal tibial torsion and a slight forefoot varus. Throw in a ACL reconstruction on that side and a hallux limitus on the other side, with a little bit of a shoulder impingement and lack of shoulder extension on the contralateral side, and maybe throw in a hernia surgery in there. This is not an atypical patient. Show me a study that has enough of those patients in the actual pipeline of the control study and in the end of the study. Now you can give. Now I will buy into that. That I can look at an evidence-based study and take an excerpt out of that and say that we can actually look at that type of a client. The problem is that each client is going to come in with a different set of things. I've got a history of a medial meniscal tear on one side and a partial meniscectomy on the other. I've got a little slight leg length discrepancy because I've got hip dysplasia on one side, and I've got multiple ankle sprains on the contralateral ankle, and I dislocated my kneecap and tore my medial retinaculum when I was playing football when I was a kid. And let's not forget that I did have my appendix out, so there's a scar there. And I had a kidney taken out because I'm going down a rabbit hole here. But you get the idea that you're not going to get a whole bunch of patients with these same types of scenarios. So we have to be able to think outside the box. So it's why when you guys listen to our podcast, we take snippets from a study and look at the clinical component and the evidence that they had from that. And we try to extrapolate it into something way more meaningful, to something very complicated, something called a patient, which comes in with a whole bunch of things that doesn't fit into someone else's little evidence-based type work here, because there's no study that, I guess that's my beef, is that you cannot pigeonhole someone who's looking at the big picture into studies that are very compartmentalized and expect that you're going to get something that fits into a nice little model of someone who might not have a deep well of experience and just depends on evidence-based stuff like, I only use this because that's what the literature supports. Well, that's good if those are the only patients that come into your offices, or patients with impaired ankle rocker during treadmill walking. Okay, well, what about someone who moves through the sagittal plane and the frontal plane? They're a tennis player now. Okay, well, the study didn't look at that. Okay, well, maybe we need to be a little bit more greased up on our thought process and slide a little bit around that topic in the results of that study, because it's a little different now, because we've got a patient that's moving into an axial and a frontal plane in their sport, and that's going to change the behaviors of the things that they talk about in this study. So that's my rant for the day, and that's why Ivo and I aren't going to really look at a lot of the nonsense stuff that's coming up on social media, because if you've got a good question and you really want to learn and you want our thoughts and you want to have a debate with us, you guys know how to find us. Okay, it's all in all of our social media, how to find us privately, and you can email us. But if we're not even going to look at the comments much anymore, because so many people just want to argue. It's that whole road rage things. People would say things from the next car over, but if you're standing beside the person, you never would. So we don't have time for that. We barely have time to do this stuff. So if you really want to have that good conversation, we want to have that with you. In fact, go over to Patreon, donate $1, and you kind of go to the top of the list. Just $1 a month. If everybody that listens to our podcast would do that, we'd have conversations with everybody, and we'd have the time, because the little bit of money we'd be making would offset maybe 1 or 2 more patients a week, and now we could actually take time to answer more questions. So that's my.
And we're not saying don't be evidence-based, okay?
No, we're not.
Or do preposterous stuff, but we're just saying, as Shawn said, it's all complex and unique. So unless you're looking for, left-handed albino Girl Scouts or something like that, you're not going to be able to just study that. I mean, a lot of what we talk about is neurology and biomechanics. It's not evidence-based. It's just like, this is it. This is how the biomechanics are supposed to work. So all we're doing is extrapolating that to talk about what's going on, and oftentimes offering a plausible explanation. We make a change in the system and they get better. Does it mean was that a placebo? Maybe it wasn't, as far as that. But the point is, we're trying to get results clinically. And when we shoot a video and the patient looks one way, and we make a change and we shoot the video again and the patient's symptoms are gone and they look different, we made a change. Did we fix them? Maybe. Was it just the fact that, Shawn is so handsome that they got better, in spite of what it did,
Very
who
frustrating.
knows? But the point is, and we won't get on it anymore. It's just some of the silliness has to stop as far as that, because it's just, it's detracting and it's actually hurting a lot of other people. A lot of what we talk about here is, yeah, it's a little fringy. It's out in the forefront of what it's doing, but there's really not a lot of people doing this out there.
Someone has to be willing to go out there on that edge, and I'd like to think that we are to a degree. And so, but that doesn't mean you get to sling arrows at us just because it doesn't fit your wheelhouse of what you've learned and where you are in your career education. But anyways, here's
You
the
can
bird.
sling arrows if you want to.
Go
Okay,
ahead.
it's
We're,
okay. I'm
we're,
gonna wear
we're
my.
pretty quick for old guys. Yeah.
That's it. That's it. Anyway, you want to talk about this slide, so go
Not
ahead.
much, because this went way longer than I thought, and this is just an example of the bird's eye view. Look at the complexities there. We've got the antiphasic and phasic movements. We've got the right leg in extension. We've got the left arm in extension. Oh, wait a minute. That's going to create a posterior diagonal sling. We've got the right arm in flexion. We've got the left leg in flexion. Oh, there's going to be an anterior sling there. And then neurologically, we're hooking these things up to work. And what's going to happen if it's not that perfectly symmetrical like this? Throw in a shoulder impingement on that right shoulder and posterior impingement on the left shoulder. Just something simple like that. It's going to skew that arrow. Stu McGill talked about low back pain patients, and in low back pain patients, these arrows are narrower, meaning the step length, and the arm swing are less grandiose, because that quite requires because the larger swings require wider arrows here, which puts more torsional load through the motor units, through the spinal units. And so if you've got back pain and it's made worse by compression, which is what axial loading can do, or shear forces, those patients are going to narrow out these arm and leg swings, because then they can narrow out the shear and the compressive forces and reduce their back pain. So you also see a nice step width here. What would a narrow step width do? A narrow step width, because of the neurologic linkage, may cause a more narrow arm swing. You may see an arm crossing the body in the front. And often when you see that, you see less arm extension on the opposite side. So there are things that you can see from the top. Now, you don't have to have a camera above to see this, but you have to, in your mind, be able to stand in front of the patient on a treadmill and see these things happening, so that you can transpose the thought of, okay, that arm's crossing the midline. That's an axial thing. They've got a narrow step width that's creating a steep angle of attack, which means they're going to have better control of rotation at the hip, or better foot tripod strength and anti-pronation type durability at the foot. If they can't do that, the knee may pay for it, and they may move into valgus loading at the knee. Maybe just simply increasing the step width will help them reduce some of that, get them into their glutes, help them level out the pelvis, and normalize arm swing. So, this is just another way to look at a client, and we will go into these types of slides like this, and we will often come back to these slides when we're trying to make a case for what we see in someone and maybe how to fix them. So just some thoughts here. And again, can you control the torso rotation, which you see is slightly to the left here, and the pelvis rotation, which is slightly to the right? Okay, that's your core musculature. Okay, how is your anti-rotation capabilities isometrically or eccentrically from left to right or right to left? If there's a weakness there, then you're going to get a spin, and now you're going to get a deviation of this upper torso and the lower torso, and you're going to get a change in this antiphasic gait. So just some thoughts there. And now hopefully you're seeing that, and I know I easily could bring in, but we don't have time. Oh, what about the head? That's kind of where all this is controlled. What about vision? What about vestibular? What about balance? What about tracking? If you're watching something, if you're a tennis player, if you're trying to target on something. So it really gets very deep, and then we'll take these big topics in the master class, and then we'll break it down into, okay, what if that patient right here had a hallux rigidus on that right foot that's behind them? It's going to impair hip extension. What's that going to do to the hip? Or the glute. Okay, it might be a little bit weaker. What happens if the glute's a little bit weaker? More hamstring recruitment, more paraspinal recruitment. That can create low back pain. Oh, in a recent podcast, these guys talked about muscle atrophy in joint pain or joint distension at a local level on the ipsilateral side. Well, what's that going to do to the pelvis in the front? Could inhibit the lower abdominals. Now they're going to an anterior pelvic tilt, putting more load into the anterior hip, creating some cam or pincer type setup during the flexion phase on the opposite side. So obviously we're going down some very hypothetical things here, but we need to be able to have this kind of a conversation with you, and you need to be able to juggle these things quickly in your head if you're going to help a client. Otherwise, it's going to take you an infinite number of treatments to try and help a client, and as it did for us at the beginning when we were trying to learn this, because we pretty much had to teach ourselves this stuff. But hopefully we can speed that process along for you guys.
This dude has issues.
This dude could have issues. Yeah.
Look at his head rotation.
Yeah,
he should be looking straight ahead.
Yes.
So he's to the left. He's got RoboCop disease. So he also has a forefoot adductus on the left, the right-hand side here. He doesn't have that on the left. So he's got asymmetrical feet down in here. So, but anyway, that's another story for another day.
Yes. All right. Well, that's a sampler of our masterclass without a video case, without corrective exercises. This is just a touch of kind of the rabbit holes we like to go down, and we will try to break these things down into a little bit more logical process. But I'll be honest, maybe we won't, but that's what will extend the course out into maybe 20 classes instead of 10. So Ivo and I just like to get on and talk, because when I hear him talk, I think of things and I learn things and I conceptualize things differently, and hopefully I do the same for him. And that's what we want to bring to you guys. So it won't be a perfect class, because there is nothing such, but we hope to take this so deep that you feel like you're drinking from a fire hose and you're actually getting something out of it. So
thanks, guys.
Thank you. We'll